And if you want to start. Hello, everyone, and welcome to the inaugural Grand Rounds for the Minnesota Regional Spinal Cord Injury Model System, or SCIMS for short. We're really glad that you could all join us today. Minnesota Regional Spinal Cord Injury Model System is funded by the National Institute on Disability, Independent Living, and Rehabilitation Research, or NIDILRR, to support innovative projects and research in the delivery, demonstration, and evaluation of medical, rehabilitation, vocational, and other services to meet the needs of individuals with spinal cord injury. Next slide. SCIMS represents an exciting new partnership among the following institutions: Courage Kenny Rehabilitation Institute, Mayo Clinic, Regions Hospital, and the University of Minnesota. In addition, our community collaborators on the next slide include Minnesota Spinal Cord Injury Association, Unite to Fight Paralysis, Get Up, Stand Up to Cure Paralysis, Paralyzed Veterans of America, United Spinal Association, and the North American Spinal Cord Injury Consortium. The system collectively provides a multidisciplinary continuum of care for people with spinal cord injury, including emergency medical services, acute care services, acute rehabilitation services, and post-acute services. My name is Leah Hansen. I'm the Director of Neuroscience Research at HealthPartners Institute, affiliated with Regions Hospital and part of SCIMS. A few housekeeping notes before we get started. This meeting today is being recorded and will be posted on our website. And due to the large number of registrants for today's webinar, we've placed all of your lines on mute to reduce audio feedback. However, we encourage audience participation using the chat functions. If you have a question for the presenter, please enter that into the chat and, the question and answer, and I will be moderating that. If you have a technical or logistical question, we ask that you submit those in chat and direct those to Dan Kelly, who'll be working behind the scenes. And again, I want to extend a thanks to Dan from the University of Minnesota, who's working behind the scenes to make these webinars possible. On the next slide, the title of today's presentation is The Effect of an Adaptive Exercise Program on Chronic Inflammation in Spinal Cord Injury. And now I'd like to introduce today's two speakers. Dr. Stephen Jackson is the Clinical Program Director of Spinal Cord Injury Medicine at Regions Hospital and an Adjunct Assistant Professor in the Department of Rehabilitation Medicine at the University of Minnesota. He is also the co-chairman and medical advisor for health equity and the medical director of patient experience at Regions Hospital. He's led several research projects in spinal cord injury, including this current award through the Minnesota Office of Higher Education to investigate the effect of exercise on chronic inflammation in spinal cord injury. Dr. Amanda Herman is a research associate in clinical neuroscience research at HealthPartners Neuroscience Center, part of Regions Hospital, and an adjunct assistant professor in the Department of Rehabilitation Medicine at the University of Minnesota. She has a background in neurorehabilitation research and is the principal investigator on 2 Minnesota state-funded clinical trials, including this current award. I will pass the ball to you, Dr. Jackson. Thank you. You are on mute.
That's a presentation one-on-one, especially during a pandemic, to come off of mute. So thanks, everybody. Thanks for having us, and I'm honored to be alongside my partners to be the inaugural presenters for our grand rounds. So I've been charged to say that we have no conflict of interest to disclose for this presentation. So thank you, and I'll get started. Next slide. So diving right into our research project, chronic low-grade inflammation is linked to cardiovascular and respiratory disease. And what we know is that 2 of the most common causes of death in people living with spinal cord injury has been cardiovascular disease and respiratory disease. Inflammation has also been linked to a lot of other medical complications, including obesity, pulmonary complications, diabetes, as well as poor wound healing. So although some levels of inflammation in the body can be considered good, like inflammation that occurs during injury repair, chronic inflammation can have negative consequences, as we kind of talked about. Fortunately, chronic inflammation after SCI could likely be reduced through modifiable risk factors, as described in a minute. So, biomarkers of inflammation are elevated in individuals with spinal cord injury, and a couple of studies show that. So, biomarkers, what they are, they're measurable substances, and excuse me for those that already know this, but they're measurable substances from the body, for example, in the blood serum, such as C-reactive protein, which is not only an acute phase reactant or an inflammatory marker, but it's a marker of also inflammation and cardiovascular disease. It was found to be elevated in adults with chronic SCI. Also, pro-inflammatory cytokines such as IL-6 and IL-1, as well as tumor necrosis factor as well, were linked to, or should I say, found to be increased in those with chronic spinal cord injury, and also found to be involved in not only inflammation, but also infection. Finally, other biomarkers that we think about, we think of antiganglioside immunoglobulin, which are antibodies that are typically also present in autoimmune diseases such as Guillain-Barré. These two have also shown to be elevated. So what we're doing is trying to paint a picture that biomarkers are found to be elevated in those that have chronic spinal cord injury. However, exercise, which is sort of the crux of our project that we'll kind of get into, has been shown to reduce inflammation, but there are some limitations. So due to limitations in things like mobility, individuals with SCI sometimes are sedentary and inactive, and thus things like muscle atrophy and damaged muscle innervation can sort of get in the way and maybe reduce the effectiveness of exercise in terms of fighting the chronic inflammation that we have already noted. In addition, exercise conditioning in persons with SCI can be pretty complicated. The benefits can be counterbalanced by both, again, ineffective exercise activities, the inability to have that amount of response to exercise that would be deemed beneficial, and thus individuals with SCI may be limited in their ability to achieve an anti-inflammatory effect, hence the anti-inflammatory benefit from exercise. So how do we counteract that? So while exercise has been shown to reduce biomarkers of inflammation and increase the release of anti-inflammatory proteins in healthy individuals, it has not been extensively examined. So let's talk briefly about a couple of studies. And again, there was basically a scarcity of evidence with regards to studies that both link exercise as well as inflammation. So in one study, they looked specifically at CRP, IL-6, as well as tumor necrosis factor alpha, and they were all reduced in individuals with spinal cord injury after participation in a 10-week cycling exercise program. In another study, CRP and ESR, or erythrocyte sedimentation rate, were both reduced in individuals with SCI following a 6-week body weight supported treadmill training program. But here's the kicker though. These studies included very small sample size. We're talking 18 and 14 respectively, and they didn't include a control group, and examined biomarkers immediately after the program included only cardiovascular exercise, excuse me. So in another study that included both individuals with SCI as well as multiple sclerosis, there was a significant decrease in tumor necrosis factor alpha after one exercise session. But these results included both patients with SCI and MS, and only a single exercise session. So obviously there were some limitations noted here. So the generalization of results, the long-term effects and effects of strength training were not clearly known and clearly grasped from these studies that were done. So while there is limited evidence that an exercise program can reduce inflammation in individuals with spinal cord injury, exercise has been shown to have other important benefits. So a recent review found evidence that exercise can improve fitness. So we're talking cardiovascular fitness, strength, power output in individuals with SCI. Another report reported evidence that exercise can greatly improve the physical and psychosocial well-being of individuals with SCI. As a result, if the barriers to exercise participation in those with SCI can be overcome, then individuals may have multiple positive health benefits. So for this study, we anticipate that a 12-week adaptive exercise program will reduce chronic inflammation and improve overall health in individuals with SCI. So essentially, we feel like if we can overcome those barriers, we can achieve the benefits from the exercise and reduce the inflammation that we're talking about. Next slide. So our specific aims are as follows. We would like to examine the effect of a 3-month/12-week exercise program on inflammation, strength and cardiovascular health, and quality of life. And we feel that as a result of this exercise program, inflammation will be reduced, strength and cardiovascular exercise health or cardiovascular health will improve, and quality of life will improve. So our outcome measures are also as follows. For aim 1, in order to assess inflammation, as mentioned, we're going to be measuring the biomarkers of inflammation, namely CRP, IL-6, and tumor necrosis factor alpha. And Amanda will talk about that momentarily in terms of the study design and the individual details about that. Aim 2, in order to improve strength and power, we're going to do the 1 repetition maximum chest press test. We're going to do a 6-minute cardiovascular test, as well as looking at submaximal exercise test, which will measure heart rate. And then for aim 3, we want to look at quality of life. So we're going to have patients do the SCI QOL short form. And you can go to the next slide, and we have some details about that. A lot of different categories in order to assess quality of life in this particular short form. So we feel that we'll be able to paint with a broad brush to assess these 3 aims. Next slide. Inclusion criteria. So I won't read the entire slide, but just want to highlight a couple of things. You guys can see the age, 18 to 70. Diagnosis of SCI and post-injury greater than 6 months. So the idea here is to get past at least the early part of healing and recovery, so as not to recruit folks that are newly injured, such as 1 month or 2 months. We didn't have any specific levels of injury or age classifications because, again, we didn't want to limit those that not only desire to participate, but also we want to be able to study the effects of chronic inflammation in all individuals with SCI. And maybe we can find, different specifics regarding level of injury as well as age classification score. And so we want to learn as much as we can, but at the same time, not limit those that want to participate in this exercise study. And again, so the inclusion criteria basically was rooted and grounded in those that can participate in the specific exercises that we are going to be offering during the study. Next slide. So a lot of exclusion criteria, and through just talking to Dr. Herrmann and Dr. Hansen offline and others on our rehab team, we came up with what we think is a comprehensive exclusion criteria. A lot of them are pretty explanatory, I think. And if there are any questions, maybe at the latter part, we can definitely go back to the exclusion criteria. As always, with anyone that does research, particularly clinical research, we want to make sure that our patients are safe, that they are well informed, and that not only do they benefit from the exercise or from the study, I should say, but we also get results that can help others. So but we can definitely come back to this. And is there anything I want to highlight? I don't think there's anything on here I want to highlight. We can come back to it. So I think Dr. Herman will jump in and kind of talk some specifics regarding the study design and finish us off. Dr. Herman.
Great, thanks, Steve. Okay, so for the study, participants will be randomized into one of two groups. So the first group, participants will undergo a first pre-treatment visit. And so for all the pre and post-treatment visits, patients will come and undergo a blood draw so that we can assess for the inflammatory biomarkers. They'll also undergo the strength and cardiovascular testing. And then they will undergo the spinal cord injury quality of life surveys. So they will fill those out via email survey. So we plan to send those through REDCap, which is the Research Electronic Data Capture, which is an online, so a web-based secure system that allows us to both capture data and send surveys. So that will allow the patients to complete those sort of on their own time because they're quite lengthy. So they will undergo that first pre-treatment visit. Then they will participate in the 12-week exercise program, which is 3 times a week for 12 weeks. Then they will participate in a post-treatment visit, undergoing those same assessments mentioned. Then there will be a 12-week delay and a follow-up second post-treatment visit. For participants that get randomized into the second group, they will undergo a delay period. So they will first come and do the pre-treatment visit. Then there will be a 12-week delay. Then they will undergo another second pre-treatment visit. So this period of time allows us to essentially have a control group of patients who are not exercising to compare to those who are exercising. But of course, we want all patients to be able to experience the exercise program. So after that second pre-treatment visit, they will enroll and participate in the exercise program for 12 weeks, 3 times a week for 12 weeks. Then they will come back and do a post-treatment visit, wait again for that 12-week follow-up period, and then they will do that final post-treatment visit. So the statistical analyses are being conducted by our biostatistician from HealthPartners Institute. She plans to run analysis of covariance and paired t-tests for the inflammatory biomarker outcomes as appropriate. She also plans to do paired t-tests or Wilcoxon sign rank tests for the secondary and tertiary outcomes as appropriate. So the study will be held at HealthPartners Neuroscience Center. The exercise components will take place in our rehab gym. So these are just a couple photos of our gym space and some of the equipment that we have available for participants to use. The specific exercise sessions will be about 1 hour in length, as I mentioned, 3 times a week for 12 weeks. So that hour will consist of about 30 minutes of aerobic exercise and about 20 minutes of resistance or strength training and 10 minutes of flexibility core balance training. So I'll go into these in a little bit more detail, but for endurance training, we have the functional electrical stimulation cycle available, an upper body ergometer and wheelchair ergometer. And for strength training, we have the Include strength machine, resistance machines and bands, and cuff weights, as well as some other adaptive equipment for patients to utilize. And then the flexibility core balance will include active, passive, and active assisted, as well as some functional activities such as mat exercises. We really want the program to be an adaptive exercise design and sort of individualized to each participant's abilities. So as I mentioned, we have a lot of adaptive equipment available. So participants could utilize the functional electrical stimulation leg and core cycle. This it uses electric surface electrodes on the skin and transmits electrical pulses, so that can allow individuals with little or no lower limb voluntary movement to be able to pedal and cycle, to be able to exercise. We also have the Pro 1 upper body ergometer, which is an arm exerciser. So this includes a removable seat and a wheelchair platform for easy wheelchair access. We also have the wheelchair ergometer from Wheeler's Paramill. This is a treadmill that's designed to fit manual wheelchairs and allows for both forward and backward cycling motion. And then for strength training, we have the Include Strength machine by Include Health. This also has movable seating to allow for wheelchair access and the ability to secure the wheelchair, and also has dexterity-free handles for those with some dexterity issues. So the main question of all of this, right, is who cares? What is the point of all of this? Why should anybody care about this project? Well, HealthPartners is an integrated healthcare system. We provide insurance, we deliver care, and we also conduct research and education. So if we have positive results from this study, we're well positioned to initiate conversations with HealthPartners insurance stakeholders to explore opportunities for reimbursement for exercise services for patients with spinal cord injury. So, of course, we also hope that all of our patients see health benefits that participate. So if we see reduced inflammation, patients could also subsequently have a decreased risk of cardiovascular and respiratory disease, other chronic illnesses, diseases, or comorbidities, and then a potentially improved quality of life. Also, a benefit is that the program and the study as a whole are free of cost, so no cost to patients for participating, and they'll also be compensated for their time. And we really want to individualize the program, as I mentioned. So looking at all of our participants as individual people and knowing that they all may have different abilities. So we want to adapt the exercise program to their abilities while keeping in, the ACSM guidelines for exercise regarding strength and aerobic exercise. And then lastly, we have existing programming through our Neuroscience Center and Regents Hospital Rehab called the NeuroWell programs. And this consists of multiple programs, but one of them being exercise programming for patients to continue to pay and come to these exercise programs if they choose. So it'd be a smooth transition into this program. Or we could alternatively assist them with transitioning into the community if they choose. But I did include our program pricing. So we have both private and small group exercise sessions that are held either in person or virtually. And then we also have an FES cycle program. So there's a cost breakdown for that. The services, as I mentioned, are private or group sessions. We also have a manual wheelchair group and then the FES cycle group. So patients prefer to continue with functional electrical stimulation. And then, as I mentioned, either in person or virtual opportunities. These programs aren't just for patients with spinal cord injury. So if they continue in the programs, they may be participating with individuals with other diagnoses as well. So we have programs that patients can participate in if they have diagnoses such as Alzheimer's, brain injury, or Parkinson's disease. And anyone who is interested can email neurowell@healthpartners.com for more information. But this is a smooth transition for patients if they'd like to continue. So to summarize, long-lasting inflammation in the body is related to both heart and lung disease, which are the two most common causes of death in patients with spinal cord injury. We also know that people with spinal cord injury have been reported to have higher levels of inflammation in their bodies compared to individuals who are considered healthy. We know that exercise is a way to reduce chronic inflammation. However, it hasn't been extensively studied in patients with spinal cord injury. And we know that patients with spinal cord injury are often sedentary or inactive due to multiple barriers to participation in exercise. So the main goal of this study is to understand if a 12-week adaptive exercise program can reduce chronic inflammation in people with spinal cord injury. And as I mentioned, people will be randomized into one of two groups to start exercise immediately or to experience a 12-week delay before beginning exercise. So the study is currently under IRB review. We're hoping that it gets approved soon. But if anyone is interested or you have patients who might be interested in participating, you or the patients can call the phone number on the screen or email clinical trials at healthpartners.com. And we can also distribute the study flyers once those are IRB approved. I also have our references available for those who are interested. And then I will go ahead and pass it back to Leah.
Thank you so much to both of you for an excellent presentation. We really enjoyed hearing about your research study. I'd like to encourage people to type questions for the speakers into the question and answer chat. And while we do that, I'd like to introduce our discussant for the presentation today. Tiffany Elliott is an occupational therapist, a mother and primary caregiver to her son, Jordan, who sustained a traumatic incomplete spinal cord injury at the C4-5 level in 2018. Tiffany's son lives at home with her, and she provides assistance with all self-care tasks, transfers, and daily needs. In addition, Tiffany is a fierce advocate for her son's ongoing health needs, overall well-being, and continued recovery. Tiffany is an ambassador for the Christopher and Dana Reeve Foundation and a member of the Minnesota Regional Spinal Cord Injury Model Systems Community Engagement Committee. Tiffany, thank you so much for joining us today.
Thank you for having me. I would just like to start off by sharing a little bit more about my son's story and his continued journey. So as my bio mentioned, in 2018, Jordan was attending college in North Dakota. One night he was hanging out with his basketball teammates and a couple of his friends when he was introduced to THC pills. Shortly after ingesting those pills, Jordan started to have hallucinations and he attempted to run through a wall, which is how he sustained his C4-C5 incomplete injury. After he was injured, he was airlifted from North Dakota to the University of Minnesota to have his surgery. He spent a couple weeks in the ICU before being transferred to Courage Kenny and Minneapolis, where he then remained for the next 3 months undergoing inpatient rehab. Jordan then discharged directly home. And at that point, he started participating in intense adaptive exercise programming and continues to do so today. And so for us, we have seen major benefits with his ongoing participation in adaptive exercise programs. It is my belief that it is essential for individuals living with spinal cord injuries to have access and opportunity to participate in adaptive exercise programming. Like I said, the benefits that we have seen include improvement in quality of life, improvement in overall well-being, and then as this research project talks about, the benefits of longevity of life is so important. So I am really excited about this research project. I think it will only help prove the benefits for individuals living with spinal cord injuries. I do know that one of the barriers to having opportunity to participate in adaptive exercise programming is the lack of insurance reimbursement. And so that kind of leads me to a couple questions, if that's okay. My first question would be, what do you feel are some of the key components of this study that could lead insurance stakeholders to consider reimbursement for adaptive exercise programming? I know for us personally, right now we have been denied coverage based on a couple of factors. One being that we were told that it is considered experimental, and the other being that currently the way that we code for reimbursement of adaptive exercise programming is not being done adequately. So I'm just wondering what you think are some of those key components that might convince insurance stakeholders to reconsider their current stance.
So I'll start off by saying thank you, Tiffany, for your support, and thank you for sharing your story and the story of your son. We appreciate that. And, you know, like I say, we hope to make good with this study and make a sizable impact with regards to our goals with this study and beyond. Having said that, number one, make no mistake about it. You know, the challenge of coverage for exercise is not a new one, as you've already, you know, talked about. And even in other areas, even, you know, exoskeleton studies, you know, there have been challenges with getting insurers to cover it, although the benefits have been, you know, sort of proven. I think with regards to this study, I think it's multifactorial. So just starting with the quality of life, using the short form that covers a lot of areas that make up quality of life will sort of, you know, help substantiate the claims of the qualitative benefits from exercise. But then we're looking at specific measurables, which are facilitated by experts in the field in terms of exercise, that hopefully, you know, again, we can open the eyes of insurers to show that this is a benefit. It's not just experimental. It's not just something you can do at the YMCA. Nothing against the YMCA, but, you know, I have, you know, gotten that message where you can exercise anywhere. Well, I think the fact that this is adaptive exercise, I think that, you know, we've shown, and many studies have shown, you know, the benefits. Again, you talk about longevity or life expectancy, or decreasing chronic inflammation, which leads to, you know, the two main causes of death after spinal cord injury. So to wrap that all up, I think having validated measures that we're using, having something that also talks about not only what we're going to look for and find quantitatively, but qualitatively. And then the fact that, you know, we are all experts in our field that are doing the study. That plus, I think there's strength in numbers. So this being produced from this group, this model systems group, also may be something that might be different, because I think it's not just me and Dr. Herrmann and Dr. Hansen and our team, but you know, although this is coming from our specific site, this is a team effort in terms of this model system group. So I think hopefully there'll be some strength and hopefully that'll substantiate what we find as well. So.
Great, thank you for that. My next question is, as I reviewed the inclusion criteria, it speaks that participants will need to be able to achieve adequate active range of motion at the elbow and wrist. Can you describe better what that would mean? And then also why there is a need to have 90 degrees of active shoulder flexion?
Sure. Okay, making sure I'm still not muted. So again, I'll start with the second part of your question. We wanted to make sure that with regards to the exercises that are specifically utilized in this study, we want to make sure that participants can do them. So that's why we got really specific with 90 degrees, because there's going to be a maximal chest press exercise. So basically we work backwards. We looked at, well, what are the exercises that we're going to ask our participants to do, and then include that in our criteria of inclusion, because again, we wanted to maximize the number of participants that we had. We didn't want to say those that are C6 and above were excluded. if you are C6, but you happen to have, enough wrist extension and, or let's just say generalized function to participate in the study, then we want to include you. And could you please repeat the first part of the question?
I felt like the description for being able to achieve adequate active range of motion of the elbow and wrist was vague, and
Sure.
just didn't quite understand that.
Sure. I think, and Dr. Herrmann, you can also help me if I don't include everything here. But one of the things that we thought about, and it's actually a separate entry in terms of our exclusion criteria, was spasticity or spasm or increased tone. And you may know, you may not know, tone can get in the way of exercise. And so if a person has, an increased degree of spasticity, again, they may not be able to achieve the range of motion necessary to perform the different exercise tasks as laid out in the study. And so I guess there was another way of also highlighting the fact that, having spasticity that's managed would likely be advantageous in terms of being a participant that's able to be included. Dr. Herrmann, anything else on that? Just want to make sure I'm giving the question justice.
Yeah, I'll just kind of summarize and add that what you mentioned about being able to perform the exercise testing. So to be able to do the strength test, the 1 rep max chest press, like Dr. Jackson mentioned, and then also that cycle ergometer. It's like a 6-minute submaximal exercise test where they'll have to use the arm ergometer cycle. So as Steve mentioned, we really wanted to be able to include as many patients as possible. So we didn't want to define people by their injury level or those tests that are done, but really be able to look at their active range of motion and their abilities in order to include as many people as possible. But unfortunately, in order to do those strength and exercise cardiovascular tests, people would need to have some level or degree of active range of motion to be able to do that.
Just one last follow-up question to that. I did notice in some of the pictures that participants in the pictures were wearing active assist grip gloves. So is that something that would be then considered or not considered if they didn't have adequate wrist function?
Yeah, so we do have the active hands and those grips available for use. So that's why the adequate word leaves it somewhat vague, is that we really will try to assess virtually, kind of over video, to see what degree of function people have, and then go ahead and include them and enroll them if they're interested, and then utilize whatever adaptive equipment that we have available and need to have them complete those tests.
Great, thank you. Those are my 2 questions. And I just want to personally thank you for the work that you are doing and will continue to do for individuals living with spinal cord injuries.
Thank you. Thank you very much. There are, I see 3 Q&A questions.
Yeah, let me bring some of those up. Thank you to both of our speakers and our discussant for a great discussion. And we do have some questions, and I will start with, where is the program held? We've had that question. Can you tell us where's the building, what city? Amanda or Dr.?
Yeah, so the program and all of the in-person visits will be held at the HealthPartners Neuroscience Center, which is located in St. Paul. It's right down the street from Regents Hospital, 295 Phelan Boulevard. So it will be held there, and patients would come in person for those pre and post visits, as well as the exercise program.
Thank you. And then we're going to dive into a statistical question. So the question is, are there specific covariates of interest for the Ancova model? Would you be adequately powered for examining differences in inflammatory markers with just the sample size of 20? Dr. Herrmann, do you want to tackle that one as well?
Yeah, so we have still been in discussion on, the specific covariates as well. And we've had some feedback from the research review committee as well in regards to that we need to address. But we will be, including the demographic variables and then as well as looking at the level of injury and things like that. So I would have to go back to the statistician. I don't know that we're adequately powered with only having a sample size of 20. We did originally submit with a much larger sample size and larger study, but unfortunately our budget was cut in half. So we had to kind of justify the work we were doing with a much smaller budget and a smaller sample size than we originally wanted to do. But I know that's, I didn't go into a lot of detail on the statistical analyses because we did get some feedback from the research review committee that may change a little bit of that as well. So that's still a work in progress.
Thank you. We have a request if we could stop sharing the slides so people could see all of the speakers' faces while we're in the discussion part here. Okay, the next question is about why non-English speakers were excluded. And then what might you be able to do in the future to make those barriers to research available? Dr. Jackson.
So I think in order to have non-English speakers as a part of the study, and first of all, as I said before, we want to include as many as possible and exclude as little as possible. I think some of the logistics in arranging interpreters may have been the biggest barrier. And I would say, and Amanda, please provide some feedback here if you need to. I think in the future, I think it would probably take a little bit more maybe planning and even just partnering with our interpreter services to include those that don't speak English. I mean, obviously we live in a very diverse population, and especially since we are big proponents of diversity, equity, and inclusion. So this is definitely something that when we're able to revisit this study or do something in the future, this is something that we'll look at. But I believe that was probably the biggest reason.
Thank you. There's a couple questions with this theme. You mentioned movement towards, approaching HealthPartners insurance for reimbursement of these services, but could this be applied more globally, or thinking of, coverage in other facilities or community fitness centers, or just this NeuroWell program coverage?
Well, I'll just say really quick that I'm hoping that we can be pioneers. It goes without saying that I think the first beneficiaries would be those within the NeuroWell program, simply because it's within our program, our system, et cetera. But our main goal isn't just to provide coverage for NeuroWell. We're hoping to make a sizable impact, so that through what we learn, through hopefully what we publish, we can continue to be that force that convinces the powers that be that exercise needs to be covered, and these are the reasons why it needs to be covered. So we're hoping, at some point to have a global impact, because this is not just a problem within the Twin Cities; it's a problem globally, And so we definitely want to have a big impact. But I think initially, there may be some local benefit because of how we're set up.
Thank you. And we have a specific question about the arm ergometer submax test. Will you be using the Borg scale to measure intensity, or what? Can you provide a little more detail about that? Dr. Herrmann, do you want to take that one?
Yeah, so I think that was definitely our original thought, was to use that scale. But actually, as part of the model systems, we're working on a modular project where we're having discussions around rate of perceived exertion scales and what's most appropriate for spinal cord injury patients. So I'm hoping that that will inform what we also end up using for this study, as long as the timing aligns correctly, and that we can utilize that same scale that we decide on as a group. So that, I would say, still to be determined.
Okay. So we have a more general question. I don't know that we can answer it, but I just want to bring it out because I think it's really important for us to think of as a model system. The question is, how can we create cross-network teamwork to effectively create research produced by the whole model system? Understanding the complexity of this, has this been in discussion at all? I know, Dr. Herrmann, you talked about working on a modular project as part of our model system that's bringing together the teams from all of our sites to discuss these things. It sounds like that has been able to influence the research you're conducting, which might be a good example of how we're working together as a model system. So I guess I don't expect you to have an answer to that, but I think it's really important and something we should consider. And one of the reasons that we're having these grand rounds and bringing together people from all different backgrounds and sites and to come together and talk about these issues.
Yeah, I think we're just kind of in the beginning of stages of this. Our grant was submitted prior to us receiving the Model Systems of Care grant. So we're in a unique position in that it's still under IRB review, that we can still make changes and get feedback and advice from other team members and everyone who's participating in this webinar if there's specific feedback. We haven't started the study, so we're welcoming, feedback and changes, but really working together collectively to try to, design research studies that could be inclusive of multi-sites with the model systems and really working together to kind of, create a common goal for our research activities.
Well, I'm going to put out a last call for questions for our speakers. And while we wait to see if anyone has a last question, I have one question for you both. I'm wondering, when you look at your sort of randomization scheme, you have a delayed start for one group and not the other. Are you concerned that's going to be a barrier to people wanting to participate? Or are you concerned people might withdraw in that time? Just wondering what your thoughts are on potential barriers and how you might overcome that in your design.
So this is definitely something that we discussed. So yes, there is a risk that people, once they know that, they're being delayed for 12 weeks, that they'll, want to do something else. And we hope, number one, we hope that's not the case, but if it is the case, we hope it's minimal. But here's the reason why we did it. We know, based on evidence, that exercise benefits those with chronic SCI. We know that. And so in order to have a control group, a traditional control group, meaning you would have people that wouldn't exercise. Well, we want to offer exercise to as many people as possible. So the best way to have both a control group, but offer the intervention to everyone, was to do this 12-week delay. So we knew it wouldn't be without risk, but at the same time, we didn't want to go the traditional control route, because then we know that would be half of our participants not exercising, and that would really be cause for not participating. So.
Thank you. So we have just a few comments closing comments of, please consider the voice of the person with disability in your research. And then also to look at NIDILRR's other funding mechanisms. So there's a link in the chat that people can click on if they're interested in and other funding mechanisms to maybe do something larger than a sample size of 20, like this state funded project. So I would like to thank you again for speaking with us, Dr. Herrmann and Dr. Jackson, and Tiffany for joining us as a discussant. Thanks to everyone who attended today's grand rounds. The recording for the webinar will be posted soon on the Minnesota Spinal Cord Injury Model System website, so check that out. And we hope that you can join us for our next grand rounds, which will be on February 3rd at noon. Thanks again and enjoy the rest of your day.